fit the time. Dear colleagues, let's discuss one more interesting issue: intravascular thrombextraction in acute phase of stroke. Ischemic stroke. Why do we need this? There is intravenular thrombolysis that is the only way and very effective way in acute phase. The method has a number of advantages: very brief time before the therapy, minimum volume of examination, and very brief blood tests. This method has considerable disadvantages, namely, statistics say that 10% of the patients who are admitted to the hospital they suit for the criteria of intravenous thrombolysis. Very brief therapeutic windows, up to 4.5 hours, risk of intracranial and extracranial hemorrhage complications. Intravascular ways of recanalization appeared quite recently. They are faster than thrombolytic therapy. They have longer therapeutic window, up to 8 hours, and 24-48 in vertebrobasilar area. They may be applied to persons who don't comply with the criteria of thrombolysis. It's a restricted time before the beginning of the treatment. The necessity of the general anesthesia, influence of the anatomy of the blood vessels, and fragmentation of clots and the distal fragments. These are the indications for intravenous thrombolysis. 28 as to counterindications for X-ray surgical interventions. All the counterindications are excluded related to intravenous application of thrombolytic. More patients may be operated by intravascular methods. There are different strategies of intravascular strategies in ischemic stroke: intra-arterial infusion of thrombolytic medications, intravascular thrombextraction, intravascular thromboaspirations, mechanic breaking of the clot, fibrinolysis and stenting, and temporary intravascular shunt via clot. Let's look at the intravascular clot extraction, so thromb extraction. Different devices are available. One of them is a solitaire that was designed for stent system in aneurysm. One of the clinical cases, 50 years female warfarin application. She couldn't be applied thrombolysis in 2.5 hours after the stroke. Thromb extraction was performed. Two passes, the first and the second pass of the device, many masses, the full recanalization without any neurological deficit. Another device, the thromb extraction, clot extraction may be done. It looks differently. Then stent retriever, similar, similar catch plus. It can't be used as an embolizing of aneurysm. Is designed for thrombo or clot extraction. Phanax is not available in our country, but it's a combination of two devices of a wire that can extract clot from the vessel volume. As to evaluate our manipulation in myocardial infarction, thrombolysis is a bit different. In case of a stroke, you can see that it includes a stroke number 2, then partial recanalization. 50% of the area ideal, it's a TISA number 3. As to the frequency of revascularization as a result of clot extraction or other manipulations, rather high. Otherwise, it's revascularization, all revascularization 2 to A to B and 3. If we look what kind of devices are more effective as a for revascularization, in case of TC3 is Solitaire and Mercy travel extraction, or sorry, Penumbra. SWIFT study was devoted to thrombectomy. Solitaire and Mercy compared. It showed that Solitaire has more safe and has more effective than Mercy. What's the ratio, frequency of recanalization and the outcomes? Patients with a high frequency of revascularization, the share of outcomes may be low. Why? The answer to this question, to answer this question, a recent study was done, International Management of Stroke, 656 patients, thrombolysis, intravenous thrombolysis were compared, and patients after non-effective intravascular thrombolysis. Intravascular treatment ensures stable result regardless of the diameter of the artery. Intravenous thrombolysis is more effective when small diameter vessels are impaired. It's proved then the better recanalization, the better the outcome. The higher percentage of recanalization of intravascular treatment. All the same, the conclusions are a bit different. It showed the similar safety and similar functional outcomes while using intravascular treatment and intravascular thrombolysis therapy. Patients with more severe impairment when NIS is less than 19, intravascular thrombo extraction appeared to be better because the approach IMS-3 intravascular treatment that is done after thrombolysis, it was compared only with intravenular thrombolysis. Intravascular treatment a priori in the patients with more severe impairment and patients with a minor impairment with it's SWIFT prime. It's a different design. Two groups are compared. Thrombo extraction was done together with thrombolysis, intravenous thrombolysis, and without thrombo extraction. Thrombolysis without thrombo extraction, the second group.
Well, one more case presentation. Patient with a myocardiopathy, dilation myocardiopathy, occlusion of the segment of the anterior cerebral artery and the middle cerebral artery. Well, the first step, we used thrombextraction and thrombextraction from the middle cerebral artery. The second step, thrombextraction from the right carotid circulation. Basically, we managed to break through without causing distal thromboembolism. Those, look at the patency of the cerebral vessel. Those are ischemia areas, probably due to some emboli. Hemorrhagical complications, a threatening situation. But we have to remember that just D-type complications like conflating hematoma. All other hemorrhagical transformation do not make any significant impact on outcome. As for the rate of intracranial hemorrhagical complication, so well, this rate depends from one study to another. What is it associated with? It's difficult to tell. To conclude, I would like to conclude that intravascular methods of treating stroke, ischemic stroke, allows the achievement of better outcomes of recanalizations and may be used within and outside of the therapeutic window. Uh, use, well, there are no evidences of superiority of this method, but maybe it takes place in case of more severe conditions. Now we have to develop the differentiated algorithm for combination of various methods depending on the clinical manifestation, radiology picture. Plus, we have to select the group of the most efficient devices for intravascular recanalization, and the research is still in progress. So I believe that we will have to wait for a little while. So my presentation is